Never ignore these 10 warning signs of post-stroke dementia if you're over 65. Most people completely miss number 7 until cognitive decline becomes severe. Surviving a stroke should feel like a victory. Your life was spared, you made it through rehabilitation, you're back home with your family. But here's what doctors often don't tell you. The stroke you survived might just be the beginning of a longer battle. According to research from the American Heart Association, approximately 30% of stroke survivors develop dementia within 1 year of their stroke. That's nearly 1 in 3 people. Within 5 years, that number climbs even higher. Your risk of developing dementia after a stroke is 9 times higher than someone who never had a stroke. The mechanism makes sense when you understand it. A stroke occurs when blood flow to part of your brain stops, either from a blocked artery or a ruptured vessel. Brain cells in that region die from lack of oxygen. This creates dead tissue in your brain. But the damage doesn't stop there. The stroke damages blood vessels throughout your brain. It triggers inflammation that persists for months. It disrupts neural networks connecting different brain regions. All these factors create conditions where dementia can develop. What shocked me when I researched this topic is that post-stroke dementia looks different from Alzheimer's disease. The symptoms follow distinct patterns. The progression differs. The cognitive domains affected vary. Yet most families and even some doctors don't recognize these specific patterns, attributing the changes to normal aging or stroke recovery. This means opportunities for intervention are missed. In this video, I'll reveal 10 symptoms of post-stroke dementia everyone over 65 needs to recognize, whether you've had a stroke yourself or you're caring for someone who has. Number 7 is so subtle and commonly dismissed that families watch it worsen for months before realizing it represents serious cognitive decline requiring medical attention. Before we start, I need to be crystal clear about something. This video is for educational awareness only. If you or someone you love has had a stroke and shows cognitive changes, work closely with your healthcare team. Early recognition of post-stroke dementia allows interventions that can slow progression and maintain quality of life longer. Now, let's dive into the symptoms that could help you catch post-stroke dementia early. Symptom number 10. Slowed thinking and processing speed that worsens over months. Starting with one of the earliest yet most overlooked symptoms, dramatically slowed thinking after a stroke can indicate developing vascular dementia. Here's why this happens. Processing speed refers to how quickly your brain can take in information, understand it, and formulate a response. It's the mental equivalent of computer processing speed. After a stroke, especially if the stroke damaged white matter tracts that connect different brain regions, processing speed often slows noticeably. You might notice the person takes much longer to answer even simple questions. You ask them what they want for lunch, and they pause for 30 seconds or more before responding. They need extra time to understand what you said, consider the options, and formulate an answer. Tasks that previously took minutes now take much longer. Paying bills that used to take 15 minutes now takes an hour. Following a recipe they've made dozens of times now requires intense concentration and significantly more time. Research from the journal Stroke found that slowed processing speed is one of the most sensitive early markers of post-stroke dementia. Studies using computerized cognitive testing showed that processing speed declines often appear within weeks of the stroke and progressively worsen over the following months in people who develop vascular dementia. The mechanism involves damaged neural pathways. White matter in your brain consists of nerve fibers connecting different regions. These fibers allow rapid communication between brain areas. When stroke damages white matter, signals must travel through alternative, less efficient routes. Everything slows down. Additionally, strokes often damage small vessels throughout your brain, beyond just the main stroke area. This widespread small vessel disease further impairs processing efficiency. What makes slowed processing particularly important to recognize is that it affects everything else. Because processing is slow, memory seems worse because the person can't encode information quickly enough. Language seems impaired because they can't retrieve words fast enough. Decision-making suffers because they can't evaluate options efficiently. If you notice someone taking progressively longer to process information after a stroke, document specific examples and discuss with their doctor. While some slowing is normal immediately after stroke, progressive worsening over months suggests developing dementia requiring intervention. Symptom number 9. Executive function problems affecting planning and organization. Executive function refers to higher-level cognitive abilities, including planning, organizing, problem-solving, and completing complex tasks. After a stroke, executive dysfunction often appears early and prominently. Here's why this happens. Executive functions are controlled primarily by frontal and prefrontal regions of your brain working together with other areas through neural networks. Strokes, especially those affecting frontal regions or the connections between frontal areas and other brain regions, impair these networks. The person can't plan sequential tasks effectively anymore. They struggle to organize activities they previously managed easily. Someone who paid household bills efficiently for decades now can't figure out which bills to pay first, how to write checks, or how to keep records. They might pay some bills twice while forgetting others completely. Someone who cooked complex meals effortlessly now can't plan a meal requiring multiple dishes to be ready simultaneously. They start cooking the vegetables but forget about the main course until the vegetables are overcooked. Research published in the Journal of the American Geriatric Society found that executive dysfunction appears in approximately 60% of people who develop post-stroke dementia. The problems often manifest before obvious memory impairment becomes apparent. The mechanism involves disrupted frontal subcortical circuits. Your frontal lobes generate plans and goals. Subcortical structures help execute those plans. When stroke damages these circuits or the white matter connecting them, planning ability deteriorates even though intelligence and knowledge remain relatively intact. What makes executive dysfunction particularly problematic is that it directly affects independence. Managing medications, handling finances, preparing meals, and organizing daily activities all require executive function. When these abilities fail, safety and self-care become compromised, even if the person can still remember facts and recognize people. If you notice someone struggling with planning, organizing, or completing multi-step tasks after a stroke, this suggests executive dysfunction. Occupational therapy can help develop compensatory strategies, but progressive worsening indicates developing dementia requiring medical evaluation. Symptom number 8. Difficulty with attention and concentration. Problems maintaining attention represent another early sign of post-stroke dementia that families often attribute to fatigue or depression. Here's why this happens. Attention depends on networks connecting multiple brain regions, including frontal areas, parietal regions, and subcortical structures. Strokes can damage these networks directly or disrupt the connections between regions. The person can't focus on tasks or conversations for normal periods. Their mind wanders constantly. They lose track of what they were doing or saying mid-task. They can't filter out distractions. Background noise or visual stimuli that healthy people easily ignore completely derail their attention. Watching television becomes difficult because they can't follow the plot. Reading more than a paragraph requires multiple attempts because they lose focus and have to reread the same lines repeatedly. Research from Neurology Journal found that attention problems appear early in post-stroke cognitive decline and predicts subsequent dementia development. Studies using attention tests showed that stroke survivors with attention deficits were 3 times more likely to develop dementia within 2 years. The mechanism involves damage to attention networks. The thalamus acts like a relay station filtering information and directing attention. Frontal regions provide top-down control of attention. Parietal regions orient attention in space. When stroke damages any of these regions or their connections, attention becomes fragmented and difficult to sustain. What makes attention problems particularly impairing is their effect on other cognitive functions. When you can't maintain attention, you can't encode memories properly. You can't follow complex reasoning. You can't solve problems effectively. Attention underpins almost every other cognitive ability. If you notice increasing difficulty with attention and concentration after a stroke, particularly if the person seems unable to focus even on activities they previously enjoyed, this warrants evaluation. Attention training exercises may help, but progressive worsening suggests dementia developing. Symptom number 7. Changes in emotional control and personality. This is the symptom most people miss completely, dismissing it as depression, stress, or just being upset about stroke-related disabilities. Changes in emotional regulation and personality can be among the earliest signs of post-stroke dementia. Here's why this happens. The frontal lobes, particularly areas in the prefrontal cortex, regulate emotions and control impulses. These regions allow you to modulate emotional responses appropriately for social contexts. When stroke damages frontal regions or their connections, emotional control deteriorates. The person displays emotions that seem inappropriate or excessive for the situation. They might cry easily over minor things. A touching commercial brings tears streaming down their face. They might become angry or irritated over trivial frustrations that previously wouldn't have bothered them. They snap at family members over small issues. They might laugh at inappropriate times, finding humor in serious or sad situations. Their emotional responses seem disconnected from social context. Additionally, personality changes can emerge. Someone who was always considerate and polite becomes blunt and tactless, saying hurtful things without apparent awareness. Someone who was cautious becomes impulsive, making rash decisions. Someone who was emotionally expressive becomes flat and indifferent. Research from the International Journal of Geriatric Psychiatry found that emotional and personality changes appear in approximately 40% of people with post-stroke dementia, often appearing before obvious cognitive symptoms. These changes are frequently misdiagnosed as depression or attributed to psychological adjustment to stroke-related disabilities. The mechanism involves damage to circuits regulating emotion and social behavior. The frontal lobes connect to limbic structures, including the amygdala, that generate emotions. This circuit normally allows appropriate emotional expression. When damaged by stroke or vascular disease, the regulation fails. Emotions become labile, swinging rapidly. Social awareness diminishes. What makes these changes so commonly missed is that families interpret them as psychological rather than neurological. They think their loved one is depressed about stroke effects or upset about lost abilities. They don't recognize these as symptoms of brain damage affecting emotional and personality circuits. If you notice emotional instability, inappropriate emotional reactions, or personality changes after a stroke, particularly if they seem disproportionate to circumstances, discuss with a doctor. These changes indicate brain dysfunction requiring evaluation, not just psychological counseling. Symptom number 6, increasing difficulty with language and communication. Language problems after a stroke are common immediately following the event, but progressive worsening or development of new language problems months later suggests evolving dementia. Here's why this happens. Many strokes cause initial aphasia, difficulty with language production or comprehension. With rehabilitation, many people recover significant language function, but if language abilities progressively decline after initial recovery, or if new language problems develop months after the stroke, this indicates additional brain damage from developing vascular dementia. The person has increasing difficulty finding words. Conversations are punctuated with long pauses as they search for common words. They might use the wrong word, calling a fork a spoon, or describing objects in roundabout ways because they can't retrieve the proper word. They struggle to follow complex conversations. Multi-person discussions become overwhelming. They can't track who said what or follow topic changes. Their own speech becomes less fluent and grammatically simpler. They use shorter sentences with simpler vocabulary than previously. Research published in Stroke found that progressive language decline after initial stroke recovery strongly predicts dementia. Language problems worsen more in vascular dementia than in typical aging, distinguishing pathological decline from normal age-related changes. The mechanism involves damage to language networks. Language processing requires coordination between multiple brain regions, including Broca's area for speech production, Wernicke's area for comprehension, and connecting pathways. Small vessel disease and recurrent small strokes damage these networks progressively. What makes progressive language decline particularly significant is that it indicates ongoing brain damage beyond the original stroke. It suggests either recurrent silent strokes or progressive vascular disease affecting multiple brain regions. If you notice language abilities worsening months after a stroke, particularly if the person had initially recovered language function, this requires medical evaluation, including brain imaging to assess for new strokes or progression of vascular disease. Symptom number 5. Memory problems following specific patterns. Memory problems are expected with dementia, but post-stroke dementia creates distinctive memory patterns that differ from Alzheimer's disease. Here's why this happens. In Alzheimer's disease, the hippocampus, your brain's memory center, is affected early and severely. Memory problems are typically the most prominent symptom. In post-stroke dementia, memory problems depend on stroke location and vascular damage patterns. If the stroke directly damaged the hippocampus or thalamus, memory problems can be severe and appear immediately. But often, in post-stroke dementia, memory problems develop gradually and have specific characteristics. The person struggles more with recall than recognition. They can't spontaneously remember information, but can recognize it when given choices. Ask them what they ate for lunch and they can't recall. Show them pictures of 3 meals and they recognize which one they ate. They have difficulty with working memory, the mental scratch pad that holds information temporarily while you work with it. They can't remember a phone number long enough to dial it. They lose track of conversations mid-sentence. But long-term memories from before the stroke often remain relatively intact. They remember childhood events clearly, but can't remember what happened yesterday. Research from Alzheimer's and dementia found that the pattern of memory impairment helps distinguish vascular dementia from Alzheimer's disease. Vascular dementia typically shows better recognition than recall and more problems with working memory relative to long-term memory. The mechanism involves specific brain regions and pathways affected by vascular damage. Small strokes in the thalamus impair memory encoding. Damage to frontal subcortical circuits impair working memory and retrieval. But areas storing long-term memories may remain relatively spared. What makes the memory pattern important diagnostically is that it guides treatment. Different cognitive rehabilitation strategies work better for vascular versus Alzheimer's type memory problems. If you notice memory problems developing or worsening after a stroke, this warrants occupational therapy evaluation and safety modifications at home. Symptom number 4. Problems with spatial abilities and getting lost. Spatial cognitive abilities, including navigation, depth perception, and visual spatial processing, often decline in post-stroke dementia. Here's why this happens. The right hemisphere of your brain, particularly the parietal lobe, processes spatial information. Many strokes occur in the right hemisphere or affect white matter pathways involved in spatial processing. The person gets lost in familiar places. They can't find their way back from the bathroom in their own home. They take wrong turns in their neighborhood. They can't judge distances accurately. They reach for objects, but their hand stops short or overshoots. They misjudge the height of curbs and stumble. They have difficulty with spatial tasks like parking a car, navigating crowded spaces, or fitting objects into containers. Research shows that spatial cognitive deficits appear in approximately 50% of people with post-stroke dementia. These problems significantly increase fall risk and make independent mobility dangerous. The mechanism involves damage to right hemisphere parietal regions and their connections. These areas create your internal spatial map and process visual spatial information. When damaged, your sense of space and navigation fails. What makes spatial problems particularly dangerous is that they're often not obvious until the person attempts navigation independently and gets lost. Families may not notice problems because they're always with the person. If you notice spatial difficulties or navigation problems after a stroke, this warrants occupational therapy evaluation and safety modifications at home. Symptom number 3. Rapid stepwise decline rather than gradual progression. The pattern of cognitive decline differs between Alzheimer's disease and post-stroke dementia in a distinctive way. Here's why this happens. Alzheimer's disease typically causes gradual, progressive decline. Abilities deteriorate slowly and steadily over months and years. On a graph, it looks like a gentle downward slope. Post-stroke dementia often progresses in a stepwise pattern. The person functions at one level for weeks or months, then suddenly declines to a new lower baseline after another stroke or vascular event, then stabilizes at that lower level. On a graph, it looks like descending stairs. Research from the Lancet Neurology identified stepwise deterioration as one of the most reliable distinguishing features of vascular dementia. Studies tracking cognitive function over time found this pattern in approximately 60% of post-stroke dementia cases. The mechanism is straightforward. Each new stroke or significant vascular event destroys additional brain tissue. Function drops suddenly when new damage occurs, then stabilizes as the brain adapts to the new deficit. What makes this pattern clinically important is that it suggests opportunities for prevention. If you can prevent additional strokes through aggressive vascular risk factor management, you may prevent or slow further decline. If you notice sudden step-downs in cognitive function after an initial stroke, particularly if these coincide with new neurological symptoms like weakness or speech changes, the person may be having recurrent strokes requiring urgent evaluation and more aggressive preventive treatment. Symptom number 2: gait changes and increased fall risk. Walking problems appear early and prominently in post-stroke dementia, more so than in Alzheimer's disease. Here's why this happens. Walking requires coordination between motor control regions, balance systems, sensory processing, and cognitive functions, including attention and spatial processing. Strokes often affect multiple systems involved in walking, particularly when small vessel disease damages deep brain structures and white matter. The person's gait becomes slower and more shuffling. They take shorter steps and move more cautiously. They have difficulty with turns and changes in direction. Balance becomes unstable, particularly when attempting to do two things simultaneously, like walking while talking. They may freeze when approaching doorways or narrow spaces. Research published in the Journal of the American Geriatric Society found that gait changes appear earlier in post-stroke dementia than in Alzheimer's disease and are more severe. Studies found that people with post-stroke dementia showed gait abnormalities an average of 2 years before obvious cognitive symptoms. The mechanism involves damage to motor circuits and integration systems. The basal ganglia help initiate movements. The cerebellum coordinates movement. Frontal regions plan and execute motor sequences. When vascular disease damages these regions and their connections, walking becomes impaired. What makes gait changes particularly important is the fall risk they create. Falls can cause serious injuries, including hip fractures and head trauma. Additionally, gait problems often force nursing home placement earlier because of safety concerns. If you notice walking becoming more difficult after a stroke, physical therapy may help. But progressive worsening suggests evolving dementia requiring comprehensive evaluation. Symptom number 1: urinary incontinence developing months after stroke. Taking the top position, development of urinary incontinence months after a stroke strongly predicts post-stroke dementia. Here's why this happens. Bladder control involves complex coordination between the frontal lobes that provide voluntary control, subcortical structures that regulate reflexes, and spinal cord circuits. This system is vulnerable to vascular damage. The person develops sudden urgency, needing to urinate with little warning. They may not make it to the bathroom in time, leading to incontinence. This occurs even though urological examination shows no infection or structural bladder problems. Research from Stroke Journal found that urinary incontinence developing within 1 year of stroke predicts dementia development with high accuracy. In studies following stroke survivors, those who developed incontinence within the first year after stroke were 5 times more likely to develop dementia within 2 years. The mechanism involves damage to frontal subcortical circuits controlling bladder function. When these circuits are damaged by stroke or small vessel disease, voluntary control over bladder reflexes is lost. What makes this symptom the most predictive is that it indicates widespread brain dysfunction affecting frontal regions and their connections. This suggests significant vascular damage beyond just the original stroke site. If someone develops urinary urgency or incontinence months after a stroke, particularly if urological causes have been ruled out, this warrants comprehensive cognitive evaluation because it strongly suggests developing vascular dementia. What you must do next. If you or someone you love has had a stroke and you recognize multiple symptoms from this list, early action can make a significant difference in outcomes. First, understand that post-stroke dementia is not inevitable. Aggressive vascular risk factor management can prevent progression. Control blood pressure strictly. Target below 130/80. Manage diabetes tightly. Treat high cholesterol. Stop smoking immediately. These interventions prevent additional strokes that cause stepwise decline. Second, request comprehensive cognitive evaluation. Don't let doctors dismiss symptoms as normal after stroke. Formal neuropsychological testing can document specific deficits and track changes over time. Brain imaging should be repeated to assess for new strokes or progression of small vessel disease. Third, optimize treatment of vascular risk factors. If current medications aren't achieving target blood pressure or blood sugar control, discuss more aggressive treatment. The goal is preventing additional vascular events. Fourth, consider cognitive rehabilitation. Occupational therapy and speech therapy can provide strategies for compensating for cognitive deficits. Cognitive training exercises may help maintain function. Fifth, implement safety modifications at home. If spatial problems or gait changes are present, fall prevention becomes critical. Remove tripping hazards, install grab bars, improve lighting, consider monitoring systems. Which of these symptoms surprised you most? Share your experiences in the comments and subscribe for more information on protecting brain health after stroke.